Welcome to the deep dive. Today we're going to tackle a really important topic for anyone looking to get a solid grasp on childhood illnesses: pediatric pneumonia.
Mm-hmm.
Think of this as your sort of high-yield session. We're pulling out the essential information you need to understand this condition quickly.
Exactly. We've sifted through clinical overviews, basically the revision notes for pediatric pneumonia, and, pulled out the core stuff to make it easier to remember.
Yeah, our mission is pretty straightforward. It gives you a clear picture of pediatric pneumonia covering all the angles.
Right.
We'll look at what it actually is, the common causes, the usual suspects, you could say,
Yeah.
who's more likely to get it, what's actually happening in the lungs, what else it might look like, who it tends to affect,
Mm-hmm.
how it typically shows up, how we diagnose it, what we do about it, the prognosis, and, any potential problems or curveballs.
Got it.
So if you're aiming for that concise but comprehensive understanding, you're definitely in the right place. We've done the distilling for you.
Let's do it.
Okay, so let's kick off with the most basic question. What exactly is pediatric pneumonia?
Okay. Put simply, pediatric pneumonia is an infection in a child's lungs. It causes inflammation in the tiny air sacs, the alveoli.
Okay.
And this inflammation leads to them filling up with fluid or sometimes pus.
Right, so inflammation and fluid in the air sacs.
Exactly. And the key thing is it can be caused by different things, usually bacteria or viruses. Fungi are less common.
Okay.
And it's worth remembering the severity can really vary, and kids can pick it up either out in the community or sometimes while they're already in hospital.
Right, community or hospital acquired.
Got it. So if it's an infection causing this inflammation, what are the specific culprits? What typically causes pediatric pneumonia?
Well, there's quite a mix. On the bacterial side, Streptococcus pneumonia is, a really common one.
The classic pneumococcus.
That's the one. Then there's Haemophilus influenza, though thankfully serious infections from H. influenza type B are much rarer now because of the Hib vaccine.
Ah, good point. Vaccination impact. Huge impact. A real public health win. Shows how well vaccines work. We also sometimes see Staphylococcus aureus.
Okay. And viruses.
Viruses are very common causes too.
Yeah.
RSV, respiratory syncytial virus, is a frequent one, especially in the little ones, the infants.
Right.
Then you've got the influenza virus, parainfluenza viruses, adenovirus. Those are all common players.
So a whole range of viruses.
Yes. And just to reiterate, fungal pneumonia isn't something we see often. It's typically in children whose immune systems are compromised for some reason.
Understood. So knowing the causes, who is actually most likely to get pneumonia? Are there specific risk factors we should be aware of?
Yes, definitely. Age is a big factor. Infants and young children, their immune systems are still developing, so they're just generally more susceptible to infections, including pneumonia.
Makes sense.
Premature birth is another key risk. Preemies often have lungs that aren't fully mature, plus their immunity might be weaker.
Okay.
And as you'd expect, any kind of immunodeficiency, a weakened immune system, significantly increases the risk.
Right.
Also, children with existing chronic conditions, things like asthma, cystic fibrosis, or congenital heart disease, put them at higher risk.
Okay, so underlying health plays a role.
Absolutely. And one more really important one,
Yeah.
exposure to tobacco smoke. It's a well-known risk factor, damages the respiratory system, and makes it easier for infections to sort of get a foothold.
That's a crucial environmental factor.
Mm.
Okay, so these bugs get into the lungs. What actually happens then? Can you walk us through the pathophysiology?
Sure. So the pathogen, the bacteria or virus, usually makes its way down into the lungs and gets into those air sacs, the alveoli.
Right.
This arrival triggers the body's inflammatory response. The walls of the air sacs get inflamed.
Okay, the defense mechanism kicks in.
Exactly. And that inflammation leads to mucus and fluid building up inside the alveoli. Think of it like those tiny air pockets getting clogged up.
Oh, okay.
And that buildup, that fluid and mucus, directly interferes with the lung's main job, getting oxygen from the air into the blood. So lung function is reduced.
Got it. So inflammation leads to fluid, which blocks oxygen transfer. Simple explanation for a complex process. Now, if a child comes in with respiratory symptoms, it's not always pneumonia, right? What else could be going on? What's on the differential diagnosis list?
That's a really important point for clinicians. Several things can look quite similar. Asthma, particularly an acute flare-up, can cause wheezing, cough, difficulty breathing. If a child has inhaled something, a foreign body, That can cause sudden respiratory distress and lung inflammation too.
Oh, right, like a small toy piece or food.
Exactly. Then there's pneumothorax air leaking around the lung that can cause sudden chest pain and breathlessness.
Yeah.
Less commonly, especially in older kids maybe, cardiac issues causing breathing problems, cardiac dyspnea could be considered.
Okay.
And we also need to think broader than just infection about other causes of lung inflammation or pneumonitis. This could be hypersensitivity pneumonitis from inhaling certain allergens or dusts,
Right.
or inflammation from smoke inhalation, or even aspiration pneumonitis if, say, stomach contents get into the lungs.
So quite a few mimics to consider. Good to keep those in mind. Now, how common is this? What's the epidemiology look like, particularly in the UK?
Well, pediatric pneumonia is definitely a significant cause of illness among UK children. And globally, it's still a major cause of mortality, sadly.
Mm-hmm.
We know the rates are higher in the younger age groups, infants and kids under 5. That fits with the risk factors we talked about, like the developing immune system.
Yeah.
Getting exact UK-wide numbers is a bit tricky. Diagnosis and reporting can vary. But if we look at European data, it gives us a pretty good idea.
Okay, what does that show?
The estimate is around 33.8 cases per 10,000 children under the age of 5.
Right.
Compare that to about 14.4 per 10,000 in kids over 6. So quite a difference.
Definitely weighted towards the younger ones.
Yes. Although it's worth remembering, something like bronchiolitis is even more common in that very first year of life.
Ah, okay. Good distinction.
And, as we mentioned before, invasive Haemophilus influenza infections, which used to be a big cause of bacterial pneumonia and meningitis, are now thankfully rare because of the vaccination program.
Right, the Hib vaccine again. Okay, so it's common, especially in under 5s. How does it actually look? What are the typical signs and symptoms parents or doctors might see?
It can present differently depending on the child's age, but there are common features. Respiratory symptoms usually dominate. So a cough is very common, might be dry, might be productive. Fever is typical.
Mm-hmm.
Breathing faster than normal tachypnea, or having difficulty breathing, seeing them work hard to breathe.
Okay.
Then there are more general symptoms too, like chest pain, feeling really tired, or generally unwell malaise, not wanting to eat or drink much.
Loss of appetite.
Exactly. And in more severe cases, you might see cyanosis, that bluish tinge around the lips or fingertips, which means oxygen levels are low.
That sounds serious.
It is a sign of severity, yes. And when a doctor listens to the chest with a stethoscope, they might hear crackles, sort of bubbly sounds, or maybe reduced breath sounds over the affected area of the lung.
Okay. And you mentioned some specific physical signs earlier that are quite suggestive.
Yes. Key things to look for. Tachypnea, rapid breathing is a big one, and the threshold changes with age.
Right, the memory tip.
Yeah, the memory tip helps. Think roughly 60 breaths per minute or more for babies under 6 months. Then about 50 or more for 6 to 12 months, and 40 or more for kids over 12 months old.
60, 50, 40. Got it.
It's a useful guide. Also look for nasal flaring, the nostrils widening with each breath. That shows they're really working to get air in.
Mm-hmm.
And chest indrawing, or recession where the skin pulls in between the ribs or under the rib cage or above the collarbones with each breath, another sign of increased work of breathing.
Okay, signs of respiratory distress.
Exactly. And of course, a low oxygen saturation measured with a pulse oximeter, usually 95% or less on room air, is a very significant finding.
Those age-specific rates are really handy. Does the presentation differ much between, say, a newborn and a toddler?
Oh, absolutely. Newborns and very young infants, they might not have that classic cough.
Really?
Yeah, it can be subtle. Instead, you might see things like grunting noises with breathing, poor feeding, being really irritable or lethargic, maybe a fever, maybe cyanosis. The cough might be absent or minimal.
Okay, so grunting and poor feeding in a neonate. Think serious infection.
Definitely. So here's an example question. A 2-week-old comes in with poor feeding and grunting sounds. What serious respiratory condition needs to be high on your differential? Pneumonia is a key possibility there.
Good example. What about slightly older infants?
Infants, say up to a year, they're more likely to have the cough, the tachypnea, maybe grunting, definitely the chest indrawing. Feeding difficulties are common, and sometimes you might hear a wheeze along with it.
Okay. And toddlers or preschoolers?
In that age group, there's often a story of a preceding cold or upper respiratory infection. Then they develop a cough, fever, maybe complain of chest pain or tummy pain even. Sometimes they vomit, especially after a bad coughing fit.
Right. And older children?
Older children tend to present more like adults, I suppose. A wider range of symptoms, often look more obviously unwell, can describe their pain better.
Okay. And when examining a child?
The examination involves careful observation. How are they breathing? Are they distressed? Counting the respiratory rate accurately is vital. Listening carefully to the chest, auscultation, for those crackles or decreased sounds. Sometimes percussion, tapping on the chest, can give clues about consolidation. That's when the lung tissue becomes dense with fluid.
Right, looking for those specific signs of distress and consolidation. So, based on all these clues from the history and examination, when do doctors decide to do tests? And what investigations are usually considered?
Well, for many kids with milder community-acquired pneumonia, you might not actually need any investigations. The clinical picture can be clear enough.
Okay, so not always necessary.
Not always. But if the child is quite unwell, needs admitting to hospital, or if the diagnosis isn't clear, then tests are definitely considered. A chest X-ray is the common one. It helps look for those shadows, the infiltrates or consolidation in the lungs.
The X marks the spot memory tip.
Exactly. Think X-ray for X marks the spot of infection. But remember, it's not always needed for outpatients, and it often can't reliably tell you if it's bacterial or viral just by looking at the picture.
Good point. What about blood tests?
Blood tests might be done. A full blood count, or CBC, can show a high white blood cell count, suggesting infection. CRP, C-reactive protein, is another marker for inflammation that might be elevated.
Okay.
Blood cultures trying to grow bacteria from the blood are actually not often positive in straightforward pneumonia, maybe only in more severe cases.
Right. Any other useful tests?
A nasopharyngeal swab from the back of the nose, or sometimes a throat swab, can be useful to identify specific viruses or bacteria, especially if you're trying to pinpoint the exact cause, maybe during flu season or an RSV outbreak.
Mm-hmm.
And pulse oximetry, measuring oxygen levels, is absolutely crucial. It guides management, tells us how severe the lung involvement is.
So it sounds like the approach is quite selective with testing.
Yes, generally trying to do only what's necessary.
Mhm.
Quick results are always valuable. In specific situations, other tests might come into play, like a TB skin test if tuberculosis is a concern, or a test for mycoplasma if that's suspected clinically.
Okay.
And if there's a significant pleural effusion, that fluid around the lung, draining some of that fluid for analysis and culture can be very helpful.
Right.
It's also interesting, research suggests that in primary care, for kids with cough and RTI, routinely checking SATs and CRP doesn't massively change the overall outcome or prognosis.
Interesting nuance there. Okay, so let's say we've diagnosed pneumonia or strongly suspect it. How is it managed? What's the treatment approach?
Right? Management really depends on how sick the child is, their age, and whether we think it's more likely bacterial or viral.
Okay.
If bacterial pneumonia is suspected, then antibiotics are the key. The usual first choice is amoxicillin.
Standard choice.
Yes. If the child doesn't get better on amoxicillin, or if there's a reason to suspect an atypical bacterium like mycoplasma, then alternatives like macrolide antibiotics might be used.
Okay, antibiotics for bacterial. What else?
Supportive care is absolutely vital for all children with pneumonia, whatever the cause. That means rest, encouraging fluids to stay hydrated, and managing fever with things like paracetamol or ibuprofen to keep them comfortable.
Makes sense. Basic but important.
Crucial. Then oxygen therapy is needed if their oxygen levels are low, below 95% usually, or if they're showing significant signs of respiratory distress.
Right, supporting their breathing.
Exactly. And hospitalization becomes necessary for the more severe cases, if they need oxygen, IV fluids, or if complications develop.
Okay, and prevention.
Prevention is key too. Vaccination is incredibly important. The routine childhood immunization schedule includes the pneumococcal vaccine, PCV, and the annual flu vaccine is recommended too, especially for those at higher risk. These help prevent some of the common causes.
So, thinking about managing these kids, what are the main considerations for the doctors?
Well, firstly, recognizing who needs to be in hospital. Low oxygen levels are a major trigger for admission.
Right.
Providing that good supportive care and also reassuring the family is really important. Using oxygen effectively and monitoring oxygen levels with pulse oximetry is essential to guide how much support they need.
Mm-hmm.
A chest X-ray might be used initially for diagnosis confirmation, especially in hospital, or later to check for complications if they're not improving as expected.
Okay.
And the treatment really needs tailoring to the individual child, their age, severity, likely cause. And, there's an increasing awareness, especially in milder cases, possibly viral, to consider maybe delaying antibiotics or sometimes not using them at all, but always with really clear safety netting advice for parents.
Right, explaining exactly when to come back if things change. That makes sense. So what's the general outlook? If a child gets pneumonia, what's the prognosis typically like?
Generally, the prognosis is very good for most children with pneumonia, particularly if it's caught and treated appropriately.
That's reassuring.
It is. Recovery really depends on things like how severe the infection was initially, the child's age, their underlying health, do they have other conditions,
Yeah.
and how quickly treatment was started.
Okay.
Most children make a full recovery without any lasting problems. Complete resolution is expected.
Good.
However, it's important to know that severe cases, or cases where treatment is delayed, can lead to serious issues like respiratory failure or sepsis, that overwhelming body response to infection.
Right. The potential downsides.
Yes, if it's a bacterial pneumonia, possible complications include that consolidation becoming persistent, bloodstream infection, septicemia, pus collecting around the lung, empyema, a lung abscess, or that fluid collection, pleural effusion.
Okay.
But things like respiratory failure or death are thankfully rare in previously healthy children. The risk is higher if there are pre-existing lung conditions or a significantly weakened immune system. And again, vaccination for high-risk kids, those with heart or lung disease, for example, is so important for prevention. Also, just to mention again, smoking in the home is a significant negative factor for recovery.
Definitely worth repeating. And any evidence for supplements like zinc?
No, current evidence doesn't really support using zinc supplements routinely for treating or improving outcomes in childhood pneumonia.
Okay, good to know. You've mentioned complications a few times. Can we just summarize those potential issues that can arise?
Sure. While most kids do fine, complications can happen. On the respiratory side, we've mentioned pleural effusion, empyema, lung abscess, and in severe cases, respiratory failure. Sepsis, the body's severe reaction to infection and potentially septic shock, are serious systemic complications.
Right.
A rarer but potentially serious long-term one is bronchiolitis obliterans. It causes scarring and blockage of the small airways.
Okay, long-term lung issue.
Yes, and there is a possibility of some residual long-term lung damage, though this is more likely in kids who had severe pneumonia or have underlying lung problems anyway.
And any non-respiratory ones?
Very rarely, neurological complications like meningitis or even a brain abscess have been reported, but these are exceptional.
Okay, thankfully rare. This has been incredibly comprehensive, thank you. We've covered a lot of ground on pediatric pneumonia. To sort of wrap it up, what are the absolute key takeaways you'd want someone listening to remember?
I think the main things are understand the basic definition, lung infection, inflammation, fluid in the air sacs, know the common causes, mainly bacterial and viral, and recognize the main risk factors, especially young age and underlying conditions.
Right.
Be really familiar with the clinical signs, especially those age-specific breathing rates and the red flags, rapid breathing, nasal flaring, chest indrawing, low oxygen.
The danger signs.
Exactly.
Yeah.
And finally, have a good grasp of the basic management principles, antibiotics of bacterial infections likely, but crucial supportive care, rest, fluids, fever control for everyone, and the importance of oxygen when needed. Oh, and vaccination for prevention.
Perfect summary. Understanding those nuances, like the subtle signs in newborns and the huge impact of prevention through vaccines, really allows for timely help and better results for kids. It does make you think, doesn't it, about other childhood illnesses that might start off looking similar, and how vital that careful assessment and maybe targeted investigation is to really differentiate them in practice. Well, for everyone listening, we really hope this deep dive has provided a clear, high-yield overview of pediatric pneumonia.
Hope it was helpful.
And for more resources to help with your learning and MSRA preparation, don't forget to check out PassTheMSRA.com and FreeMSRA.com.